Happy New Year, everyone, and welcome to the January 2024 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. My name is Alice Cheng from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania. We are your co-hosts for this podcast series. Let me take this opportunity to also wish everyone a happy new year, and hoping that everyone has found some time to relax and recharge over the holiday season and are ready now and energized to take on the challenges of diabetes for 2024.
Well said, Mike. I too hope that 2024 will be a year filled with wonderful advances in diabetes research and, most importantly, good health and peace for everyone.
Couldn't agree more, Alice. And as per our usual, we'll be interviewing authors of feature articles as selected by the editors of Diabetes Care, followed by our rapid exchange segment where we give brief summaries of articles we found of particular interest.
Now, just before diving into this month's content, let's share an important time-limited opportunity with our listeners. The American Diabetes Association is extending a special offer exclusively for new members to the ADA. When you sign up for a new professional membership to the ADA, use the code NEW24 or NEW24 during checkout and get 25% off the yearly membership price for your first year.
That is a really great deal for the first year of membership. And I know I personally take advantage of all the ADA membership benefits. You get exclusive discounts on conferences, a subscription to Diabetes Care or another ADA journal of your choice, and with online access to all of them, a copy of the Standards of Care in Diabetes, and other member-exclusive discounts, continuing education opportunities, and access to webinars. There's just so much value.
Agreed. I think an ADA membership is the best way to gain access to an international community of professionals who share your passion and dedication in the fight to end diabetes. So if you've been considering joining the ADA, now's the perfect time. Remember, this offer is exclusively for new members of the ADA. Go to professionals.diabetes.org/membership, create your account, fill out the application, and remember to use the discount code NEW24 or NEW24 at checkout. Act fast because this offer expires March 31st, 2024. So again, that's a 25% off for new members using code NEW24 at checkout, and the offer expires March 31st. So don't miss out on this fantastic opportunity to expand your commitment to the fight to end diabetes by joining the American Diabetes Association.
Well, let's get started with the content for the January 2024 issue of Diabetes Care. In the January 2024 issue of Diabetes Care is a feature article entitled Psychosocial Care for People with Diabetic Neuropathy, Time for Action. I'm delighted to have the opportunity to discuss this perspective and care contribution with first author, Dr. Frans Pouwer, and last author, Dr. Loretta Vileikyte. Dr. Pouwer is a professor in the Department of Psychology at the University of Southern Denmark, and Dr. Vileikyte is an associate professor in the Department of Medicine at the University of Manchester in the United Kingdom, and a visiting research associate professor at the University of Miami in the United States. Welcome, Frans and Loretta. I'm so glad you could both join us.
And thank you for the opportunity to discuss the importance of psychological and social aspects of patient adaptation to diabetic neuropathy.
Frans and Loretta, congratulations to you both and your colleagues on this feature article. Your perspectives piece is a call to action to examine both psychological factors and psychosocial care for individuals with diabetic neuropathy. Your article discusses the clinical problem of underdetection and undertreatment of psychological and social determinants of health in diabetic neuropathy. Can you begin by telling us about the prevalence of diabetic neuropathy and typical presenting features, especially those that most often escape detection in practice?
Sure, the diabetic neuropathies are among the most common chronic complications, affecting up to half of people with diabetes. It is a heterogeneous group of conditions and includes sensory-motor polyneuropathy, autonomic, and atypical neuropathies, presenting with a variety of clinical manifestations. The commonest amongst them, diabetic sensory-motor polyneuropathy, may present with neuropathic pain, which has received the lion's share of attention from clinical researchers, and postural instability, which received far less attention from clinicians and behavioral scientists. Importantly, nearly half of neuropathy patients may be asymptomatic, yet those people are at risk of foot ulceration and lower limb amputations. Indeed, over a third of people with diabetes will develop a foot ulcer during their lifetime. An estimated cost of foot ulceration is higher than that of 5 most costly forms of cancer. Comorbid depression in people with diabetic foot ulcers is associated with a threefold increased mortality risk as compared to those without depression. As we know, pain affects half of individuals with neuropathy, and in spite of its negative impact on quality of life, painful neuropathy remains undertreated, with only a half of individuals achieving appreciable pain reduction. Finally, neuropathy-related postural instability is common, with nearly a quarter of people with established neuropathy reporting balance issues. The balance deficits are often overlooked by clinicians, as patients do not report their issues, attributing them to premature aging rather than diabetes-related disability. We demonstrated that neuropathic unsteadiness is the strongest determinant of depression in people with neuropathy, of poor self-rated health, and non-adherence to offloading in people with active foot ulcers. Importantly, people with neuropathy have a substantially higher risk of falling. The outcomes of falling are not only physical, but also psychological, such as fear of falling, which may lead to excessive activity restriction, functional decline, loss of independence, and subsequently reduced quality of life.
So the burden of diabetic nephropathy is huge, and I really get the sense that there's so much more that is being experienced by our patients than we're recognizing in practice. And your article discusses several self-report measures that can be used to identify types of and problems with diabetic neuropathy, including quality of life, as you mentioned, Loretta. How do you recommend implementing these in clinical practice, including how to identify actionable results?
Thank you very much for asking this central question. You're right, and if we look at the scientific literature, it has become crystal clear that there is a range of psychological problems that really can form key barriers in diabetes care. So, for example, if you look at depression, this is a common mental health problem that affects approximately 10 to 30% of the people with diabetes. And that impacts their quality of life severely, but it is also associated with many self-care behaviors. So depression is associated with poor diet, suboptimal medication use, poor adherence to advised treatment strategies, low physical activity, etc. And through that, it is also associated with a stronger risk for long-term complication and an early mortality. Other problems also include diabetes distress, fear of falling, pain, and these psychosocial problems, they're often overlooked. That is what we also know from the literature. While a range of questionnaires can be used to assess these problems. And therefore, I'm really happy that ADA in the new guidelines 2024 offer a list of questionnaires that can be used by healthcare providers. And the validated tools include the PAID, for example, Problem Areas in Diabetes Survey, but also questionnaires like the PHQ-9 that can measure depression, or the GAD-7, which can assess anxiety. However, if we look from the perspective of diabetic neuropathy, questionnaires that tap into diabetic neuropathy specific areas are lacking in the ADA guidelines. So they're not in section 5, that is focused on facilitating positive healthcare behaviors and well-being to improve health outcomes, or in section 12, that includes food care. So I think we need a working group that works on that and works on further standardization of these tools, and also to providing clear guidance to healthcare providers how to use these tools in clinical practice. And we need to develop feasible ways that actually save time and not cost time. As to your question, which tools can be used right now? Well, in our article, we describe several of them. One of them could be the brief pain inventory. but also diabetic neuropathy specific questionnaires like the NeuroQual could be used for this purpose. It is essential that these tools are being used as conversation starters. It is a quick way of learning what's going on in the patient's life, and actually also can be used to define what will be on the agenda for the consultation, so that both the person with diabetes and the healthcare provider define the agenda for the consultation. So again, screening or monitoring of emotional well-being should never become tokenistic. It should really be used by teams to start the conversation, to monitor outcomes, and to initiate appropriate care.
Well, that's terrific that these practical tools are available, and to hear that the ADA standards of care is starting to identify, even if they're not neuropathy specific yet, identifying tools that relate to some of the associated morbidity of diabetic neuropathy, and that further experience with these specific tools addressing factors of diabetic neuropathy will hopefully come in the next wave of recommendations, and as your article points out, can be implemented now and to start gaining experience in starting these conversations with our patients. And social determinants of health play a critical role in diabetes development and treatment, but they also affect diabetic neuropathy and its complications. And so can you talk to us about how social determinants of health affect diabetic neuropathy and its manifestations more specifically?
Indeed, the social factors are the root cause of health disparities. While the role of social determinants of health and diabetes risk is well established, far less is known about the role of social determinants of health in neuropathy development. There have been inconsistent findings of racial and ethnic differences in diabetic neuropathy prevalence rates. While earlier reports found no association between the race, ethnicity, and the risk of neuropathy, a recent large-scale study of nearly 6,000 participants with type 1 diabetes showed that diabetic neuropathy prevalence was higher in Black Americans, in people with low education levels, and in those lacking private insurance. Similarly, several studies conducted in the United Kingdom indicated that living in more socially deprived areas in Scotland doubles the risk of diabetic neuropathy, whereas in northwest of England, social deprivation is associated with an increased risk of painful neuropathy in both type 1 and type 2 diabetes.
And in our review, we have also described the problem of racism. So, for example, in the Behavioral Risk Factor Surveillance System study, it was clearly shown that self-reported racial or ethnic discrimination was associated with less optimal diabetes care and also more diabetes complications. And in another study, a narrative review, it was described that structural racism is associated with worse self-care behaviors and poor clinical outcomes. So racism still is a key social determinant of health that requires action, for example, by governmental policy interventions that lead to structural improvements.
And those structural improvements are so critical because care can often be interrupted and disjointed, and that can lead to progression and development of more complications. And also, painful diabetic neuropathy is difficult to treat. And so this can really negatively impact an individual's quality of life in a number of ways. And so addressing that, I learned two new concepts reading your paper, that of pain catastrophizing and psychological flexibility. Can you briefly explain these concepts and how they can affect the impact of painful diabetic neuropathy for an individual?
Yes, thanks for this question. So these are key constructs, and pain catastrophizing is actually about appraisals. So how people appraise the pain. And pain catastrophizing can be described as a set of negative cognitions related to the belief that the experienced pain will inevitably result in the worst possible outcome. Pain catastrophizing is actually a multidimensional construct that is comprised of, for example, rumination, so thoughts that come back over and over again, feelings of helplessness, and pessimistic thoughts about the pain. In a way, psychological flexibility is quite the opposite. So some people with a high level of psychological flexibility can quickly adjust themselves to new situations. So in case of neuropathic pain that crosses your path in life, or any other discomfort related to diabetic neuropathy, these people think, okay, the pain is there, but it's apparently not a sign of danger. It is really annoying, but I don't want to end up in a situation that the pain controls my life or dominates my life. It's pain, it's just pain, and despite of the pain, there's a lot of things I still can do in my life and actually want to do in my life. So that is two key psychological constructs that are important in the care of people with diabetic neuropathy. As you say, the relevance of the constructs is crystal clear in the Option DM trial, for example, that was published in The Lancet, a big study led by Professor Solomon Tesfaye. It was shown that even with dual therapy, so two different painkillers, approximately 50% of the people report a pain reduction higher than 50%. So there is a big need also for psychological therapies that can learn people to live with the pain.
Well, in addition to psychological flexibility and catastrophic thinking, I would also like to mention the importance of specific fears or anxieties that are related to some aspect of neuropathy experience. Fear of falling, for example, is common in people with diabetic neuropathy and is significantly associated with disability and reduced quality of life. And what's interesting that fear of falling is reported not only by persons suffering from neuropathic unsteadiness, but is a very prominent emotion in people with neuropathic pain. So it could be that people with neuropathic pain are also experiencing postural instability resulting in fear of falling. It could also be possible that medications used to alleviate pain are negatively impacting the people's balance through their recognized CNS side effects. Another interesting emotion is fear of amputation, which is a predominant emotion in people with diabetic foot complications and powerfully impacts adherence to foot self-care. Interestingly, its effects vary as a function of foot ulcer experience. In those people with past ulceration, fear of amputation seem to promote adherence to foot self-care. Well, those people at high biological risk of foot ulceration who have not experienced foot ulceration and in the absence of warning symptoms or signs because of neuropathy-related loss of sensation in their feet, fear of amputation induces defensiveness, resulting in a lack of foot self-care.
And so to address these problems of fear and these psychological barriers to optimal care of diabetic neuropathy and its complications, your article discusses two approaches. Cognitive behavioral therapy is one, and a second, acceptance and commitment therapy, both for reducing the impact of painful diabetic neuropathy on an individual. Can you tell us a little about each of these approaches, how they're different, and how they might each work to ease the psychosocial burden of painful diabetic neuropathy?
Yes, certainly. So cognitive behavioral therapy, let's start with that. It is mainstream psychological intervention that we're talking about. And in CBT, so cognitive behavioral therapy, the therapist and the patient focus on the cognitions and on behaviors. And the goal is to change irrational beliefs or unhelpful beliefs in more rational beliefs and helpful beliefs. In case of pain, for example, this could be thoughts like, oh, I'm a weak person, I cannot bear the pain, I cannot live with this pain is totally unbearable. These thoughts in CBT will be changed into, okay, the pain is there, it is not a pleasant thing in my life, but it's not my whole life, it's part of my life. And I can live a good life despite of the pain. ACT is different, so acceptance and commitment therapy. There's also a focus on beliefs and cognitions in ACT, in acceptance and commitment therapy, but they are not deliberately changed. So in ACT, people learn to observe their thoughts and without changing them. In ACT, there's also meditation strategies that people learn, and they learn to commit to values that they are important for them as an individual. So that could be values in the domain of family or career or spirituality or what you can do for the community. And the general goal of ACT is to increase psychological flexibility and the ability to contact the present moment more fully and as a conscious human being. So yeah, this is in short both ACT and CBT, two interventions that can help people with diabetic neuropathy. that are not well researched in this particular area. That is something that I want to emphasize. They can be delivered in face-to-face therapy, in individual therapy. They can be delivered in groups, and nowadays also online. So I think we as researchers need to initiate good trials that make these interventions available also for people with diabetic neuropathy.
Yeah, certainly I feel that these approaches are sorely underutilized in clinical practice as potential interventions for helping our patients suffering with diabetic neuropathy. I also learned about another more direct intervention that has developed remarkably with recent advances in technology. And so now for those patients with diabetic neuropathy at increased risk for developing a diabetic foot ulcer, there are smart wearable technologies that can provide continuous plantar pressure feedback, for example, to the individual. And so can you tell us, how are these evolving digital health technologies being implemented in clinical practice today, and how do you envision their use in the future?
Indeed, the introduction of smart technologies where plantar foot temperatures and pressures can be monitored and feedback provided in real time through audio and visual alerts is indeed promising and represents not only a paradigm shift in foot ulcer risk screening and monitoring, but crucially, it transforms foot care education, as by allowing patients to visualize their personal foot ulcer risk, digital technologies are likely to enhance their active participation in foot ulcer prevention. Today, most of the digital devices are still undergoing rigorous testing in terms of their ability to effectively monitor foot ulcer factors and prevent foot ulceration. While promising, these technologies introduce additional layers of complexity to preventive foot self-care with technology design, and yet there's little research examining patient and provider acceptance of digital technology. And patient-reported factors such as perceived usability and ease of use of smart wearable technologies, along with costs and integration with healthcare, were previously identified as important determinants of patients' acceptance of digital technology.
Well, I certainly expect to see, as the use of wearables and digital health technology is increasing across many domains in medical practice, that we'll begin to see our patients taking advantage of these technologies. And I expect to see a dramatic increase in use in the future and look forward to seeing that. And so finally, I wanted to see what other takeaway messages you might have for our listeners.
Well, mine is sort of a summary message. It is clear that neuropathy has a wide-reaching impact on people's lives. With respect to neuropathic pain, utility of psychological constructs such as pain catastrophizing specific fears and psychological flexibility that were just described by Frans deserve further investigation. And we need adequately powered, high-quality trials to establish the effectiveness of psychological therapies. And I'd like to stress that postural instability is common, burdensome, and yet underappreciated. Therefore, large-scale randomized controlled trials addressing not only biomechanic, but also psychological challenges associated with neuropathic postural instability are urgently needed.
Yes, I fully agree with Loretta, and that's why we need to team up. And that's also why we wrote this call for action. Healthcare providers working in the area of diabetic neuropathy should not overlook the psychosocial factors in the area of diabetic neuropathy. And we need to work together on the further standardization of these online assessments, also making them available in a diabetic neuropathy specific way, making sure that healthcare providers ask and discuss the right questions and initiate better care, provide optimal and more comprehensive care for people with diabetic neuropathy. And hopefully in the nearby future, we can help to improve the ADA standards of care over the next years. And yeah, I also want to end with a statement that, from my perspective, psychologists should be standard members of diabetes care teams. That is a crucial thing that I would like to emphasize.
And I, as a clinician, as a physician, managing people with diabetes, couldn't agree more with you, Frans, that we need to engage psychologists in research and in clinical practice.
Hear, hear. Dr. Frans Pouwer and Loretta Vileikyte, thank you both very much for sharing your expertise with us today. I really appreciate all I've learned from your paper and our discussion. and hope that I can apply this new knowledge towards improved identification and care of diabetic neuropathy for my patients. I encourage our listeners to access the full article in the January issue of Diabetes Care.
One of the feature articles from the January 2024 issue of Diabetes Care is titled Diabetes in South Asians, Uncovering Novel Risk Factors with Longitudinal Epidemiologic Data by Dr. Alka Kanaya, internal medicine specialist and professor of medicine, epidemiology, and biostatistics at the University of California, San Francisco. She is also an associate editor for Diabetes Care. It is a real pleasure to have you with us today, Alka.
Thank you. It's a pleasure and privilege to be with you today, Alice.
So first and foremost, I want to congratulate you for receiving the 2023 Kelly West Award for Outstanding Achievement in Epidemiology from the American Diabetes Association. You delivered a brilliant award lecture at the 2023 ADA Scientific Meeting in San Diego, and this feature article represents the content of that award lecture and more.
Thank you. It was my honor to present the work of our entire team and collaborators.
Well, it really was a fantastic lecture, so congratulations for that part too. Now, the focus of your research has been on the South Asian population. So what populations does the term South Asian actually represent? And how does this differ from the term Asian American, which has been used in many surveys as well as data sets?
Asian American is a broad umbrella term. It's a constructed racial category for the United States, and it includes people who have origins from 23 different Asian countries. So if you categorize individuals based on the geographic location of these countries, there are three distinct areas. There's East Asian, there's South Asian, and there's Southeast Asian. So our study, Masala, includes individuals who self-identify as being South Asian. They've had 3 or more grandparents who were born in the South Asian subcontinent, and that includes countries like India, Pakistan, Bangladesh, Nepal, Sri Lanka, Bhutan, and the Maldives. And South Asians represent about 23% of the global population, and there's about 5 million residents in the United States from those countries.
So why was it important then to study diabetes and atherosclerotic cardiovascular disease in the South Asian population?
Yeah, what we've learned from many other cross-sectional studies from around the world since the 70s is that individuals of South Asian origin have a higher prevalence of type 2 diabetes and atherosclerotic cardiovascular disease. And these diseases, both of them, occur at younger ages in these groups compared to other race or ethnic groups in various regions around the world. But what we don't know from these snapshot or cross-sectional studies is why. And in 2010, when we began our study, there were no longitudinal studies among any South Asian populations anywhere in the world. And that is the gap that we wanted to fill.
So you wanted to answer the why. So with that, then tell us about the Masala study and the approach that you and your team took.
Yeah, so we are using a socio-ecological model to inform our conceptual framework for how to capture different levels of data in Masala. So we're capturing data from the societal level, from community and neighborhood level, interpersonal relationship, social network level, as well as the individual level. And we wanted to look at various levels of influence on the individual's health over time. And we're also adding some novel area measures of the environment, as well as early life characteristics, immigration reasons, and more recently, biomarkers that can help integrate the individual's biology with their environment.
Very cool. I'm going to ask you a side question. How did you come up with Masala as the acronym? Because that's just the perfect acronym.
Yeah, I've been asked that question several times, and it was one of those early morning in the shower kind of moments that, something kind of just strikes you as, oh my God, that's the right name, because it resonates with people of South Asian origin, because it means a mixture of spices or a mixture of, could be vegetables. It's a mixture. And what we are trying to do is understand a mixture of variables that can lead to, health outcomes.
Oh, love it. I always love those stories as to how these ideas come about. So, Alka, who are the Masala study participants and what are some of the features about them that you'd like to highlight?
Yeah, so we've been following about 1,164 participants in the Masala study for an average of 10 years now. There are roughly equal numbers of men and women in the study, and their age group ranged from 40 to 84 at the baseline visit. And they had to have no existing cardiovascular disease to be eligible in the study. And that's because we are tied very closely in our methods to another ongoing large cohort study in the United States called the Multi-Ethnic Study of Atherosclerosis, or MESA. And they used the same exact kind of eligibility criteria because we wanted to make sure we were able to compare the South Asians to other US race and ethnic group individuals. So in our study, 98% of the population are immigrants to the United States. And what's interesting is that 83% are self-identify as Asian Indian. And so we don't have that many Pakistanis, Nepalis, Sri Lankans, Bangladeshis reflected in the cohort. So most of the data we have published to date really is mostly generalizable to Indians in the United States. We're currently in the midst of our third clinical exam, bringing back the survivors of the original cohort, but we're also expanding the cohort, adding 1,150 new Bangladeshi and Pakistani participants, because we really need to know if there are differences by country of origin in terms of risk factor profiles and outcomes among these three large South Asian groups.
So, what did you learn then about the epidemiology and the pathophysiology of diabetes among the Masala participants?
So we've learned that type 2 diabetes prevalence is higher in South Asians compared to all of the four different groups in our sister comparison study, the MESA study. And this is so even after we adjust for social, behavioral, and metabolic risk factors. And so that is something that we cannot explain away by adjusting for many levels of risk factors. And so that seems to be an important characteristic that we are trying to understand. What we've seen in those without diabetes is that South Asians have higher levels of insulin resistance, even at a younger age, compared to these four different groups in MESA, but they also have lower beta cell function, so lower insulin secretion compared to those four groups. So there's kind of a double hit here with insulin resistance and beta cell function being impaired. That seems to probably have a lot to do with the higher rates of diabetes. When we study those with diabetes, we've done analysis to understand the different subtype of diabetes in MESA and Masala. And what we found was even though all race ethnic groups in the US have, 5 different predominant diabetes subtypes, the distribution of these different subtypes really varies. And in South Asians, the most common subtype was the one that we called hyperglycemia, or the one with very poor insulin secretion and higher hemoglobin A1C and low BMI. That was almost 38% of all diabetic participants in Masala, much higher than all of the other four race and ethnic groups in MESA that includes whites, blacks, Latinos, and Chinese Americans. And what's most important about that finding is it's that group with hyperglycemia that goes on to develop incident atherosclerosis. And atherosclerosis in our studies has been measured by coronary artery calcium with repeat CT scans in every 5 years. And so we're seeing that this subtype that is very, more of this insulin deficiency subtype has stronger ties to atherosclerosis. And that is something that has not really been discussed much in the literature or really studied well, and it gives us new insights into pathophysiology.
And I think an important clinical pearl, right, to sort of be aware when we're with someone who fits that phenotype, right, just to be aware of that risk. Now, you also collected data on adiposity and body composition. So, what did that end up showing?
We measured anthropometry as well as ectopic fat depots using CT scans. So we looked at fat in the liver, fat around the visceral abdominal organs, fat in the muscle, fat around the heart. And again, we use the same CT methods and reading centers as MESA to be able to harmonize our measures and compare the groups in a valid way. And what we found was the South Asians in Masala had a lot more fat in the liver and in the visceral fat space and in the intermuscular space compared to the 4 groups in MESA. And when we modeled these ectopic fat depots, just the quantity of fat seen on CT, and we looked at those who have glycemic progression over 5 years, going from normal to prediabetes or diabetes, we found that both the amount of fat in the liver, as well as the amount of fat around the abdominal organs, the visceral fat, both of them were independently associated with enhanced or faster glycemic progression. And so these fat depots are more tied to the insulin resistance type of phenotype. And so what we know in South Asians is they have insulin resistance as well as, insulin deficiency. And it's this insulin resistance that has the ectopic fat, and that it seems to be also driving the rapid conversion from prediabetes to diabetes.
Lots of great insights. Now, let's talk about modifiable risk factors. And very interestingly, you took a systematic, multi-level approach to figure this out, which was extremely thorough. So what were some of the highlights that your group discovered about that?
Yeah, we are very fortunate to have a diverse team of investigators who include sociologists and anthropologists and epidemiologists and clinicians, cardiologists and primary care doctors. And so we were able to, use our collective wisdom to really look at many social, societal, interpersonal, and individual level factors. And some of our most interesting findings really come from the interpersonal level. And one of them is our papers that we have discussed, acculturation. We measured acculturation using 5 different scales, some that we actually constructed on our own with qualitative research before we launched the Masala study. And what we did was a kind of a cluster analysis of all of these different measures. And we developed 3 main classes of acculturation. One is the separation class, where people have retained mostly South Asian cultural beliefs, have not adopted many beliefs or behaviors from the United States. Then there's a middle large category of the bicultural group that have both adopted some American beliefs and behaviors, as well as retained some South Asian one, and that was about 50% of the cohort. And the last group is the assimilated group, the assimilation class, that is more identifies with the American cultural beliefs and behaviors and not so much the South Asian. There's about a quarter in the separation and assimilation group and 50% in that bicultural group. And what we found was it's really that bicultural and the assimilation group, the one that has, adopted more American behaviors and beliefs, that had the lowest metabolic risk factor profile, not only at baseline, but also when we look at the change in risk factors over 5 years, that these 2 groups had better measures. They had less adverse change in glucose levels, in weight status, blood pressure, and even coronary atherosclerosis. So there's more we're doing to really understand this. And as we develop, longer term follow-up of our cohort, we'll be able to kind of really nicely look at the effects of acculturation over time. Another individual level finding that is unique to South Asians is diet. And lots of people have their, theories and hypotheses on why there is so much more diabetes and atherosclerosis in South Asians. And diet has always been like the primary reason that many people put forward. And what we found in Masala, Dr. Gadgil led these analyses where she looked at the different dietary patterns, finding 3 most common dietary patterns in South Asians. One was a traditional South Asian type of diet that was high in fried snacks, high-fat dairy items, as well as sweets. And the second was a fresh fruits, veggies, whole grains, and legumes diet. And the third was an animal protein diet. And what she found when she did analyses looking at the metabolic profiles of these 3 dietary pattern groups is that the people in that first traditional South Asian diet that was really mostly a vegetarian heavy diet, that was associated with higher levels of insulin resistance as well as lower HDL cholesterol. The people eating that more, fresh fruits and veggies diet had the lowest risk factors in terms of hypertension, metabolic syndrome. The people eating that animal protein diet had higher weight, waist circumference, total cholesterol, and LDL. So what's important is the dietary patterns, those first two I mentioned, are mostly vegetarian. There's 40% of our participants are lifelong vegetarians. And so another clinical pearl is that when you are seeing a South Asian patient and talking to them about their diet and they say, oh, I'm a vegetarian, that does not give them a pass or a check that they're fine. You got to dig a little deeper to understand, well, what kind of foods are you eating in your vegetarian diet and how do you prepare those foods? Are they fried? Are they, sweets, more carbohydrate heavy? So this is really an important clinical finding that I think we can apply in our practice.
Very interesting. Very interesting. And as I'm listening to you, I'm thinking about the acculturation and then the diet and how I would imagine that there's overlap there, shall I say. So that group who was still very traditional, I imagine, probably had more of those individuals eating that more fried snacks. And
You got that right.
so I wonder how much of a link there is.
There absolutely is a link. But what is interesting about that, those acculturation classes, is when you even adjust for these dietary patterns, you still find there's an effect of that acculturation class beyond just the diet. You can also adjust for exercise and smoking and alcohol. So you can try to adjust away, like, is it all because of these main behaviors that we can measure? That there seems to be something even above and beyond just those things, but they are a big part of those acculturation classes as well.
So where does masala go from here? And what future directions will you and your group take? I mean, there's already been tremendous insights, but there's also so much more that can come. So what are you planning?
Well, right now we are collecting another round of data in our original cohort. In exam 3, we are focused on cardiac function, looking at the prevalence of heart failure with preserved ejection fraction, HFpEF. And we are also expanding the cohort, as I mentioned, adding 600 new Bangladeshi participants and 600 Pakistani participants. So we will be able to compare the 3 different main subgroups of South Asians once we complete both of these study visits in 2024. We are doing lots of new biomarker measurements using our stored samples, genomic and other omics and environmental measures. And we've been trying to get new funding to measure cognition and aging in our cohort, as well as sleep. So we're going in many different directions. And I just want to say there are many opportunities for early stage junior investigators and more seasoned investigators to get involved in writing new papers and new grants from Masala. Please contact me or Dr. Nami Kandula at Northwestern or Dr. Nadia Islam at New York University. We are MPIs, multiple PIs for Masala. If you have ideas and other ways to enhance what we're learning about the health of South Asians.
Oh, that's fantastic. Great plug for opportunities, right? For everyone who's listening. So I hope people take advantage of that. So thank you very much, Dr. Alka Kanaya, for sharing your vast expertise with us today. Not only has your work with the Masala study provided actionable understanding about diabetes and ASCVD in the South Asian population, but I think it's also provided a model of how collecting multi-level longitudinal data can successfully answer questions in understudied populations. So congratulations again on your well-deserved recognition with the Kelly West Award, and thank you for being with us today. And I encourage the listeners to read the full article in the January issue of Diabetes Care. Let's move on now to our rapid exchange segment, where Mike and I chat about some of the articles we found particularly interesting this month.
There were lots to choose from this month. Alice, why don't you get us started?
Sure thing, Mike. I'm going to start with an article by Dr. Ayodeji Sanusi and colleagues from the University of Alabama at Birmingham. They performed a retrospective cohort study of pregnant women with type 1 or type 2 diabetes who used real-time CGM to evaluate the association between CGM metrics and perinatal outcomes. The CGM metrics of interest were time in range, defined as 65 to 140 milligrams per deciliter, or 3.6 to 7.8 millimoles per liter. Time above range, time below range, glucose variability, average glucose, and glucose management indicator. The primary outcome was a composite of fetal or neonatal mortality, large or small for gestational age at birth, neonatal ICU admission, hypoglycemia, shoulder dystocia, or birth trauma, and hyperbilirubinemia. Now, of 117 patients, 83.8%, which to me sounded really high, developed the composite neonatal outcome. All CGM metrics, except time below range, were associated with neonatal morbidity. For each 5% point increase in time in range, there was a 28% reduced odds of neonatal morbidity. The optimal time in range was found to be 66 to 71%, which is consistent with the recommended levels by the international consensus on time in range for pregnancy. Another interesting CGM finding was that for every 5% increase in glycemic variability, there was a 36% increased risk of neonatal morbidity. So definitely some food for thought.
Yeah, and chewing on this one some more, Alice, the specific drivers of the increased neonatal morbidity associated with high glucose variability were preeclampsia and preterm birth, while for that associated with lower time in range were large for gestational age, cesarean delivery, and hypoglycemia. So to me, this suggests there may be independent mechanisms through which glucose variability on the one hand and hyperglycemia on the other hand may each contribute to neonatal morbidity. And so I agree this supports targeting both time in range and glucose variability for optimization in pregnancy. My first pick evaluates the use of automated insulin delivery in individuals with cystic fibrosis related diabetes, which is a very challenging form of diabetes to manage. Dr. Jordan Sherwood from the Massachusetts General Hospital and colleagues in Boston conducted a randomized crossover study of 2-week periods on either the iLet bionic pancreas system or usual care in 20 individuals with cystic fibrosis related diabetes. The study participants spent significantly more time in the target glucose range of 70 to 180 milligrams per deciliter while receiving automated insulin delivery, with a modest increase in participant-reported symptomatic hypoglycemia, although with no increase in time spent below range that was low with both conditions and no severe hypoglycemia. So these results suggest a potential benefit of automated insulin delivery in this population and warrants larger and longer-term clinical trials.
And I think would be very welcome by this population, because you're absolutely right. It's a challenging form of diabetes to manage. So being able to provide anything that could reduce the burden, because I mean, the burden of the CF itself is already substantial, and then add diabetes to the picture. So yeah, I certainly hope that this ends up panning out for the sake of the people living with this. The next thing I'm going to talk about is a little bit different. So this is talking about totally pancreatectomized people. So therefore, those who have had their pancreas removed. In those individuals, insulin is the only recommended glucose lowering treatment. Now, in this issue of diabetes care, Dr. Mil Bagdal and colleagues in Copenhagen, Denmark, investigated the effects of an SGLT2 inhibitor, in this case, empagliflozin, on fasting and postprandial glucose in 10 pancreatectomized patients and 10 matched healthy controls in a randomized, double-blind, placebo-controlled crossover study. Each participant underwent 2 3-hour liquid mixed meal tests, preceded by 2 doses of empagliflozin 25 milligrams or placebo, given the night before and the morning of the meal test. Basal insulin was administered as usual for the pancreatectomized patients, but bolus insulin was omitted. Compared to placebo, EMPA normalized fasting glucose and lowered postprandial glucose excursions in the pancreatectomized patients. Obviously, these are very preliminary data and require much larger studies, especially around safety, before this can be put into clinical practice. But I think it would be welcome by these individuals who have had a pancreatectomy to be able to inject insulin less often. They'll still need their basal insulin, of course, but if there's an option to then introduce an oral agent, I think this would be something that people would really look forward to.
Yes, and even seeing less hyperglycemia without needing more insulin and risking more hypoglycemia that can be a challenge for these patients. And it's really interesting to me to think that without glucagon secretion from the missing native islets that came out with the pancreas, that individuals with total pancreatectomy may be at lower risk for euglycemic diabetic ketoacidosis with SGLT2 inhibitor use than what we see for insulin-dependent individuals with type 1 diabetes. Now, turning to type 1 diabetes, we've been hearing a lot about its increasing incidence. And so far, this has really proven elusive to combat. Dr. Anna Parviainen from the University of Helsinki and colleagues in Finland examined the incidence of type 1 diabetes in birth cohorts from before and following implementation of rotavirus vaccination in 2009. In children under 5 years of age, the reduction in rotavirus infection was associated with a more than 20% reduction in the incidence of type 1 diabetes among this age group. While we still need to see whether rotavirus vaccination may lead to an overall mitigation of the increasing incidence of type 1 diabetes, even a delay in diabetes development from very young childhood seems to me a very positive potential benefit of this vaccination strategy.
And it's interesting to me how in the last, I would say 10 years or so, there's really been I don't know if shift is the right word, but greater emphasis on the idea of prevention/delay, if we will, of the onset of type 1 diabetes. And this whole virus hypothesis has been there for some time, and then a dietary one. And then now, of course, we have other treatments that we can actually implement as people are approaching the diagnosis of type 1. So this is a very interesting field to keep an eye on for sure. Now, the final one for me is again about SGLT2 inhibitors. And it's interesting what you had said earlier about the study of empagliflozin in the pancreatectomized patients and the issue about not having their glucagon anymore, therefore perhaps a lower risk of euglycemic DKA, because the final one I'm going to talk about is actually going to maybe raise people's anxieties a little bit, because I have to admit this one raised my anxiety a little bit. So we all know about the risk of euglycemic DKA associated with SGLT2 inhibitor use among those living with diabetes. Now, we know that the risk is low in type 2 diabetes, and we know that it's usually predictable and it's avoidable, and it often has to do with individuals who should have been started on insulin, but perhaps didn't, or were on insulin and then stopped their insulin, and usually associated with an acute illness. Now, we also know that SGLT2 inhibitors have been shown to be hugely beneficial in the treatment of heart failure or chronic kidney disease, even in those who do not live with diabetes. And in the clinical trials, ketoacidosis was not seen in those who did not live with diabetes. This month, though, Dr. Mahesh Umapathisevam and colleagues from Adelaide, Australia, described the first 2 cases of severe non-diabetic ketoacidosis after initiation of SGLT2 inhibitor for the treatment of heart failure. In both cases, the ketoacidosis was triggered by reduced oral intake from either a temporary GI condition of some sort, either be it nausea, vomiting, or in one case it was diarrhea. They presented with high anion gap metabolic acidosis with normal glucose, elevated ketones, and no other cause for the high anion gap. Ketoacidosis resolved quickly with intravenous as well as oral glucose administration, with minimal insulin administration, and that was often limited by hypoglycemia. C-peptide levels were normal while they were receiving dextrose. The authors hypothesized that rather than insulin deficiency or resistance, the drivers of ketosis in these cases were reduced carbohydrate intake, continued carbohydrate loss through glycosuria, therefore lowering the blood glucose, resulting in glucagon elevation and reduced endogenous insulin secretion, leading to fatty acid metabolism and ketosis, to meet energy requirements during an acute illness. I gotta say, Mike, reading these two cases made me uncomfortable on a couple of levels. I mean, one, it was a reminder that there are no absolutes in medicine, because I know I've been guilty of telling people, oh, don't worry about it. If they don't have diabetes, you don't have to think about this. But now maybe I need to rethink that. So that, I think, is making me uncomfortable. And then, although very uncommon, we have to have that clinical suspicion, especially when providing, I think, acute care. But the second thing that made me uncomfortable is that I fear that these reports will impede the use of SGLT2 inhibitors as organ protective drugs in the appropriate patients. I think we need to understand more, but perhaps the advice we give for sick day management with prolonged fasting to those with diabetes on these medications should also apply to those without diabetes.
Absolutely, Alice. And this article should also help in raising awareness enough and help highlight difference in management between euglycemic ketoacidosis that is more akin to the treatment of starvation or alcohol-induced ketoacidosis, where initially providing glucose is so critical. And as a contrast to more traditional diabetic ketoacidosis presenting with hyperglycemia, where initially providing insulin, of course, as well as hydration, but that it's insulin what's so important there to initiate reversal of ketosis. So it's a different approach to correction, as you point out. And so I think just increasing awareness of not every ketoacidosis is diabetic ketoacidosis, and we should be able to do a better job identifying and correcting these cases in the future. My final pick addresses the question of whether our patients with diabetes and atherosclerotic cardiovascular disease should receive antiplatelet therapy with 81 or 325 milligrams of aspirin daily for secondary prevention of cardiovascular disease events. As the authors explain, there's a bit of ambivalence in the guidelines as to what the answer should be. And so Dr. Dennis Narcisse from Duke University in North Carolina and colleagues conducted a subgroup analysis of the Adaptable study, which was an open label, pragmatic, randomized trial of more than 15,000 patients with stable atherosclerotic cardiovascular disease with and without diabetes who received either 81 or 325 milligrams of aspirin daily. The more than 5,000 patients with diabetes in the study did experience more cardiovascular disease and major bleeding events than those without diabetes, but no difference in either event rate was observed between assignment to 325 or 81 milligram dosing. What is interesting is those with hemoglobin A1C greater than when compared to less than 8% did have a higher risk for future cardiovascular disease events that was unaffected by the aspirin dose assignment. So for those with diabetes at highest risk of experiencing a cardiovascular disease event, 81 milligrams of aspirin appears the necessary dose, but is still not sufficient therapy for those not currently meeting glycemic control targets.
And I think a reminder of that need for that multifactorial approach, right, to really help reduce cardiovascular events in people living with diabetes. But thank you very much for that, Mike. And this brings us to the end of our first episode for 2024. To start the new year, remember that ADA is offering a fantastic 25% off membership dues for your first year for new members if you use the discount code NEW24 online. The offer expires March 31st, so don't delay.
And remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications when new episodes come out. Thank you for listening.